Okay, so we are going to shift gears a little bit here and talk about proximal femur fractures. In particular, a lot of this is going to emphasize femoral neck fractures, and while they are not the most common fracture that you see, they do have a very high complication rate, and we want to do everything we can to try to limit those complications for these young patients. In particular, the complications that you see are going to be AVN and then malunions, and usually the way that they fall in a malunion is into Coxa Vara. These tend to be high energy injuries. Very rarely you may see them from deliveries, but that's not very common. This is a little bit of a unique fracture because there's really an impact in the time to treatment. So if it's a Delbet type 1 through 3, that would be considered a surgical emergency. So we're going to start out with some questions. What nerve innervates the muscle most responsible for creating abduction deforming forces to the proximal fracture fragment shown in figure A? And we have the figure, that's great. The superior gluteal nerve, the inferior and superior gluteal nerve, the sciatic nerve, direct branches from L1 to L3, or the femoral nerve. And so that is going to be your superior gluteal nerve. So just as you see in adults, that proximal fragment is the attachment site for the abductor muscles, both the gluteus medius and minimus, and that's going to pull it into some abduction and external rotation. The proximal fragment is also the insertion site for the iliopsoas on the lesser trochanter, and that pulls it into flexion. So when you're positioning these fractures, whether it's for flexible nailing, spica casting, or plating, you want to take the distal fragment that you have more ability to control and put it in a position that matches the position that the muscles are pulling that proximal fragment in, which is a harder piece to control oftentimes. So there's two major growth centers that you want to be taking into account when you're looking at the proximal femur, and this is number one, the proximal femoral epiphysis, and it's responsible for around 10 to 15% of the leg length, and although 23 is highlighted here, I think the 3 millimeter per year number probably comes up more often. That's right here, in terms of calculating the impact of these fractures on leg length. And the trochanteric apophysis, so that's not going to give you as much of your length in terms of your femur, but that's where your femoral neck gets some of its length and alignment. So if there's an injury to this physis, then what happens is you'll have a shorter femoral neck, and it will go more into a valgus alignment. Rarely you may see overgrowth that contributes to Coxa Vara. So be it injured from surgery, trauma, the injury to this could put you in a coxavalgal alignment. And sometimes we can use that to our advantage also to correct Coxa Vara. Okay, next question. Which of the following best describes the vascular supply to the femoral epiphysis in children under the age of 18 months? The artery of the ligamentum teres, medial femoral circumflex artery, the medial and lateral femoral circumflex artery, or the medial femoral circumflex artery and the artery of the ligamentum teres, or all three. Okay, and as this highlights, it's all three. So just to make things easy for you to remember, kids age 3 and below, there's 3 sources of blood supply that are major contributors. So if we look here, the medial femoral circumflex artery is going to be the major supply to the femoral head, and most of that is through this lateral epiphyseal branch. That becomes more and more dominant as kids age. So when they're really young, there's also this contribution from the lateral femoral circumflex artery and the artery of the ligamentum teres. But the ligamentum teres artery is going to not contribute much after the age of 4, and then the lateral femoral circumflex sort of fades into the distance throughout childhood. There are also metaphyseal vessels that may contribute some blood supplies. These are a minor contributor compared to the vessels that we just talked about. But one thing that's of note is that while these contribute to the very young children and the skeletally mature children, during that sort of peak in childhood and adolescent growth, the physis is essentially blocking their contribution. So the Delbet classification, so this is actually a really great classification scheme because it's not only going to help you decide on your management, but it also contributes to our assessment of complication rates and will help you in terms of setting your own expectations and the families. So we're going to go through this. So the first type are the transphyseal, and these can be either 1A or 1B, and the difference between those is going to be whether or not there's a dislocation of the epiphysis. So you can see that this is one of the less common types of femoral neck fractures. It's seen in about 10% of cases, but they're the highest rate of AVN. So overall, they have about a 40% rate of AVN, and if it's the type 1B where the epiphysis is actually dislocated in addition, that is something that's associated with a nearly 100% rate of AVN. One other thing to note here is that you'll see the non-union box is blank, and that's because you essentially never see non-unions in these types of fractures. The physis is very good at making new bone. That's what it does. So these tend to heal. It's just a question of whether the blood supply gets damaged with the injury. Okay, and this is just an example showing that there's asymmetry between this physis and this physis, and that's resulting from a type 1A fracture because the epiphysis is still in the acetabulum. Okay. Moving on to the most common type that you'll see, this is the transcervical fracture, and that's about half of the femoral neck fractures and proximal femur fractures that we'll see. And this has a little bit lower rate of AVN, but it's still significant, so it's around 30%, and it has a little bit higher rate of non-union than the type 1. So this is associated with about a 15% rate of a non-union. And this is just an example, again, sort of showing you here the transcervical fracture line that you can see here. Continuing to move down the femoral neck, type 3 are the basicervical and cervicotrochanteric, and that's going to account for a smaller percentage, about a third of them, and it has almost an equal chance of AVN and non-union, both occurring in about 20% of cases. So if you want to just make your memorization easy for this AVN, you can think 40% for type 1s, 30% for type 2s, and 20% for type 3s. The fourth type, this is the intertrochanteric type. So these first three are going to be ones that you're going to emergently try to get back in position because of their super high risk of AVN if they're not managed promptly. The intertrochanteric fractures have much lower incidence of that. They can still have AVN or non-unions, but tends not to happen nearly as frequently. And in this type of fracture, there's not really a significant benefit that's been shown to getting them reduced emergently. Okay, and that's just kind of showing you an intertrochanteric fracture here. Okay, so if you're suspecting a proximal femur fracture, the first imaging that you want to get is an AP pelvis and a cross-table lateral, and that usually gives you a good sense of what your fracture pattern is. If you get these and you don't appreciate that there's a fracture there, but there's the story suspicious for it and you think it's either a non-displaced or a stress fracture, then the next step will be either a CT or MRI. An MRI has the advantage of not having radiation, but in some centers is not something that can be obtained as quickly as a CT scan to get you a more prompt diagnosis, so you have to kind of weigh those risks and benefits. In small children, there may be cases where we treat these non-operatively. If it's a 1A, meaning the epiphysis is still in the acetabulum, if it's a type 2, 3, or 4, and there's really no displacement and it's a really small child, you may be able to manage that with a spica. This is going to be the exception, not the rule. Usually these are fractures that have displacement if they occur, and we are going to want to make sure that they're adequately stabilized. If you're going to try to treat them non-operatively, you do want to follow them very closely, and so you'd be doing weekly radiographs for 3 weeks. Okay, so this is why these fractures get so much play, is that if they're a type 1 through 3 and there's any significant displacement, then there's a question as to whether or not even though there's a little bit of controversy in the literature, we generally take these fairly emergently to get them reduced and internally fixated. Now, the question, the more areas of debate are whether or not you really need to do an open reduction or not. There's some data from this paper by Kit Song that suggests that an open reduction may be a better option than a closed reduction. So in this series, they had 27 femoral neck fractures, and they had about half of them that were treated with an open reduction and had a capsulotomy, and those ones had a more anatomic reduction and a lower rate of AVN. Now, this paper has been faulted sometimes because there was a more thorough capsulotomy and decompression done in the ones that had an open treatment, and that may be the factor that had more impact in terms of the AVN than the open versus closed reduction. So our treatment protocol here has been generally position the children on a fracture table, and if after positioning them and trying to reduce them, there's no significant displacement or very minimal, like a millimeter, then fixation can proceed without an open reduction. But if at that time there's still residual displacement, then we have a low threshold for opening. If an open reduction is performed, we usually perform a capsulotomy with that. If we are doing it closed, we'll at the very least aspirate to evacuate the hematoma. Some of the attendings will also make a small incision and slide a cob up the front of the femoral neck. Usually you get sort of a rush of blood back with that, and you can decompress the capsule. So I think while the data is a little bit controversial, you probably want to err on the side of decompressing that capsule so that that's not another factor contributing to potential development of AVN. Again, as I said, closed reduction internal fixation is another option. For types 1 through 3, this is usually cannulated screws. And if they're a small child, you may also want to reinforce that with a post-op spica or abduction brace. If they're older and you have good purchase and you think they'll not be too wild, that's not always needed. Okay. So next question. A 13-year-old female falls and sustains the injury shown in Figure A. Which of the following statements is true regarding the treatment of this condition? Time to definitive surgical procedure has no effect on outcome. Number 2, open reduction with capsular decompression is contraindicated. Number 3, internal fixation with a cephalomedullary nail leads to higher union rates than screw fixation. Number 4, non-union is the most common complication if surgical intervention is performed. Next number, closed reduction and cannulated screw fixation across the physis is an acceptable form of surgical management. Okay, and here's your fracture. So again, we can see this is like a Delbet type 2 where it's going through that cervical region. Okay, so for this, there was not a lot of displacement on that one. It'll probably align nicely when you have it on the fracture table, and a closed reduction and cannulated screw fixation across the physis is an acceptable form of management and can be used in most of these cases. Now, one thing that we haven't yet emphasized is that because if we go back here, you can see there's really a small area that's proximal to the fracture if you're not crossing the physis. And so this really small area of bone oftentimes doesn't give you very good purchase. So we generally recommend in these cases crossing the physis because the leg length discrepancy that will result is a much easier problem to solve than if there's a non-union or the hardware fails, which can be catastrophic. Okay. Next question, 11-year-old female presents as a trauma patient to the emergency department after being struck by a car while walking across the street. Examination reveals an isolated injury exhibited in Figure A. In the operating room, closed reduction on a fracture table is performed and the lateral fluoroscopic image is shown in Figure B. What is the next most appropriate step? Okay, so you can see here, again, we have this Delbet 2 type fracture. When you put it on the fracture table, you still don't have an adequate reduction. So in this case, you want to proceed with open reduction and screw stabilization. Okay. Next question, a 14-year-old male sustains the injury shown in Figures A and B after a fall off the roof of his house. what is the most appropriate management: hip spica and abduction, dynamic hip screw with trochanteric side plate, cephalomedullary nail, physis-sparing cancella screws, and transphyseal cancella screws. And again here, this is kind of along that same theme. We're seeing a Delbet type 2 with a very short segment proximal to that. And so in this case, you want to proceed with transphyseal cancella screws. Next question, figures A through E are radiographs demonstrating various types of pediatric hip fractures. The risk of subsequent avascular necrosis for the radiographs seen in figures A through E is, so here, just think for a second, so the Delbet classification, it's going to be 1, 2, 3, 4 in terms of the highest to the lowest risk of AVN. And then within type 1, the 1B is where you have the epiphysis dislocated. That's going to be the highest rate. So you're looking for that type 1B to be at the start of this and for it to go 1, 2, 3, 4. So if you look here, you see here are your images. I'll give you a second to think about it. But you can see here you have that type 1B, and here you have that type 1A. So you're looking for the answer choice with B greater than A, and then it's going to be the type 2 Delbet, C, D, E, as you look at the type 3 and 4 fractures. Okay, so as we mentioned, AVN is the most common complication, and risk factors for this include age and the fracture type. And again, this is one time where the classification system really will help you. You just have to remember that the 1B is the highest within that. It's sort of a little side note of nearly 100% rate of AVN. And the etiology is a combination of this injury to the vessels directly from the fracture and displacement, and then that tamponade that can happen from the intracapsular hematoma. So that's why it's important to get it realigned well as promptly as you can, and also do everything you can to decompress that hematoma so it's not contributing. If they develop AVN, then the treatment is then generally core decompression or vascularized fibular graft. And this article out of Boston showed that in a series of 70 patients, about 20 of them were complicated by a diagnosis of osteonecrosis. And in this series, the most significant predictive factors of them failing were the amount of initial fracture displacement and the time to treatment. So really, this is one of those things where you want to get out of bed and get things going because it may save a child's hip. Coxa Vara is something that's the second most common complication. This is just when it falls into alignment where the neck shaft angle is less than 120. It is most commonly seen in type 3 fractures. And if this develops and the child is really young, then oftentimes they'll just remodel so you can observe it. But if they're in that mid-childhood range and less than about 8 years of age, you can think about doing an epiphysiodesis of that apophysis, because again, that will then encourage the neck to grow into Coxa Vara. This is only going to work if it's a fairly young patient, not something you would try in like a 13 or 14-year-old. Okay, non-union can also happen. This oftentimes is seen when the fractures fall into a Coxa Vara malunion alignment, and then if they either heal in the Coxa Vara alignment or they don't heal at all, because, and this is just like what you see in adults, if you have more of a valgus position, the compression is going to encourage healing. If you're in Coxa Vara, then it's just stress on the fracture site. So similar to what you would do in adults, to treat this you would do a subtrochanteric or intertrochanteric valgus osteotomy. Again, physeal arrest can happen either from the injury itself or from the fact that oftentimes in order to get adequate stabilization we cross the physis, but even in most cases when you think about the 3 millimeters per year you get from that physis, unless it's a really young child, even if they do get growth arrest, it's usually not something that's too dramatically significant in terms of a clinical difference. But if it does seem like it's going to be greater than 2 centimeters, then we may consider epiphysiodesis of the contralateral side. Chondrolysis is sometimes seen, but usually it's in association with the AVN. And again, malreduction, that's something that is particularly easy or particularly common in the subtrochanteric fracture. So you want to be really cognizant of those fracture forces that are deforming the proximal fragment. Infection is rare. I knock on wood, really haven't seen it with this type of fracture. If, however, you did develop a fracture, you don't want to remove all the implants. This is some time where you would want to irrigate it, debride it, treat it with antibiotics, and get the fracture to heal solidly before you took out the implants, because you don't want subsequent displacement.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.